off like? Shift over to the north lab.
We can see you, Dr. Patel.
Okay, good. Am I audible?
Yes, you are.
Thank you. Here with me, you know, is my colleague Dr. Sanjay Shah and my crew, and two great on-site moderators, Professor Akasaka from Japan, Wakayama, and Professor Raju Gulati from Mayo Clinic, Rochester. So this case, now the history. You know, the patient is a 75-year-old gentleman, hypertensive, diabetic, effort angina, class 2, normal ventricle. Failed attempt of PCI of RCA lesion by in another center. They tried for 1.5 hours. I don't know why they could not. And actually a heavily calcified 99% lesion. They have tried with Miracle and 6 and Gaia second and whatnot. We have done an angiogram and we will show the previous picture also. Can you show the angiogram? The left system is normal. This is what they have tried. I think they have not given shape to the tip of the wire, and this Miracle why they have used or Gaia second, I fail to understand, because there is a clear-cut channel, it is anti-grade. But the calcium load is extremely heavy. Now let us see what exactly is the situation. I will do a couple of angiograms. These are the angiograms we have done here, and I think in untraditional view, the lateral view, we can see a channel. Normally we don't take left lateral view, but there was an issue in identifying a particular area to enter. Again, this was the idea of Sanjay, that let us take an untraditional view lateral, and we were able to make it out. So we have taken him for TRICO. I think this case is a good educational case. How is the image quality there? Hello?
Yeah, it's okay, sir.
It's okay.
It's okay. So I see you have chosen a traditional RCA guide.
Yeah, sir, certainly. Somehow, I am in love with this guide, even for the most difficult situation. Because at least, to me, it has the least chance of doing any osteal damage. That is one part of the story. And again, such a heavily calcified lesion is many times deceiving. And here, if the osteal dissection happens, there are very high chances that it will extend in the aorta. Why I see a little bit darker image over there? I mean, is it seen well over there?
Yes, it's a beautiful live image of that.
That is all right. So in this view, it looks like it's a, let me now, yesterday in the panel discussion we discussed, this view makes me predict that we are dealing with a sort of a ugly nodule, malignant. Dr. Akat and Rajiv, what do you think?
Yeah, I agree, yes. There are two filling defects, right?
Yes.
And the distal side is much severe.
Yeah.
And we can identify the calcium deposition
Yeah.
from the proximal to the mid portion. Then, as you said, maybe the protrusion of calcium can be expected.
Yes. And the upper filling defect, calcium is certainly there, but I am afraid that there could be dissection created, created by Gaia second or Miracle 6 wire, because it was almost straight tip wire they have tried to negotiate.
So are you going to go in with a microcatheter, or are you going to go straight?
We will see. Sanjay is giving a spatial shape. We will show you the lateral view. Just take carefully, go on this back, and we have to go for the lateral view. Wait, yeah. A lateral view. Sanjay, show this camera on the wire shape. This is a very spatial shape he is giving. Zoom it. Okay. Is it okay, Sanjay? Lateral? Okay. Fine. Just show the wire shape Sanjay has given. Rajiv, it is a very interesting shape, you see.
just feed it Templars.
The mic,
Left Templars.
Sanjay's mic is not working.
It is working. We can hear
It
him.
is. Okay.
Yeah,
So now we take a lateral view. Yes. And here you can see, हमने बहुत तकलीफ ना था, he is aged. There you see the channel. There you see the channel. And looking at this tortuosity and channel, Sanjay has given a very awkward shape. This is, see, we play with the shapes of the tip of the wire because frankly I am trained in an old balloon angioplasty era and I have seen the transition of balloon angioplasty from bare metal stent and then drug eluting and whatnot. And Sanjay, of course, almost simultaneously has been trained in the same era. So we still feel that the art of intervention is equally important as the science, because nowadays, unfortunately, in young generation, they know science so well, but they are not worried about knowing the art of the medicine because of the sophistication of the equipments in the field. Rajiv, what do you think? Mike?
I think there's little doubt that we are blessed to have had the engineers work alongside us for 30 years, design of the wires, balloons, stents, and we've become very complacent with the amazing technology that helps us. But every now and then, you're absolutely right, we need to use the art of intervention.
Let's see this, the shape. Shape works. Sanjay, scout. I am just rotating on the...
This is run through, what kind of wire?
this is a workhorse. If I
Run through extra floppy, yes.
Taka, would you have put a microcatheter in, or would you
Look at this, it has crossed.
I think it's too early.
Scout, no, it's going in some branch. Small
So I
branch.
think the credit to
Sanjay,
Sanjay.
Sanjay, certainly. Look at this. There is a grip. There is a grip. Here, if I try to push my OCT catheter, it will certainly not go. And even if it goes, you know, you are not going to, it will grip, you know, the nodule will grip it. So first and foremost is, this is a case where in presumption I am going to use orbital atherectomy. What is your opinion? What is your opinion, Professor? And then the panel.
I agree.
Orbital.
We would not image this first. I think there's no chance of crossing it, and they won't tell us anything that we wouldn't do. We generally have moved back from orbital to rotational atherectomy, so that would be my choice, but I think any atherectomy technology would be fine here.
I also agree, yes. Any kind of device could not pass this lesion. At that time, we have to ablate first, right?
Yes.
And after then, image again, and finally decide how to treat.
Now I have to push my wire, but I will now be careful to cross it on the microcatheter. Get me fine cross. Fine cross is a wonderful microcatheter from Tarumo. You know,
Raji, we talked yesterday about the orbital, the eclipse child. The orbital child, the
Yes.
eclipse. So after eclipse, it's not a positive child. It looks like it failed. So we're still using that, but only for certain nodule, or in general, we're still using the orbital.
Yeah. No, I mean, I have my choice. If I feel that this nodule, as I yesterday discussed in the panel, good, bad and ugly, these three local Apex Art Institute classification for the nodule, for good or bad, I don't care, whatever, but for ugly, I have to use this. And this is an ugly nodule. Ugly nodule means, you know, it is resistant. It is absolutely resistant to balloon, non-compliant balloon. And anything else can also, you know, you can't even work with lithotripsy. Even rotablator has a high chance of complication. Orbital atherectomy, by its own mechanism of getting rotating and along with the axis, you know, trying to rotate across the, you know, near the boundaries of the wall of the inner lumen, it can ablate the bad part, and then if need be, we can do orbitotripsy or whatever. So I have nothing, the wire is not coming out, but so I'm going slowly. I have to take care of the guide catheter part.
Dr. Patel, Girish Godbole here.
Yeah, how are you?
Considering that, we kind of expected that there to be nodules and we would probably have to use orbital, would it have been an option to go with the wiper straight away instead of crossing and then exchanging with the microcatheter?
I tell you, Girish, frankly, we have not done as many orbital atherectomy to know the exact behavior of viper in this type of situation. And that's the reason I am using, the time tested, what I feel can give me success. See? Just check it. Wait. There is an issue there. This guide catheter is not now, it is not behaving the way I want it to behave. And scout, am I in? Am I in or not? No. Wire has a tendency to jump back. Okay. Oh no. No, it's not going at a right place. Just check it. There is. જો તો હવે in છે? No. So? No. Wire. I may use guide plus in this case. If I am not successful, I'll try for a couple of minutes.
What size is the guide, sir?
Guide?
6 or 7 French?
This is 6 French guide, JR. If I get a good, position of the guide catheter, I can go in also very carefully. Scout, Sanjay. Not really getting good position. Yeah, calcium, significant calcium even at the ostium.
It's in the RV branch, so I think the proximal catheter, proximal part of the RCA is so calcified.
I know. Let us go in again with the guide plus. What do you think? Let us remove this.
Dr.
Wire
Patel,
is out.
if I could, so if you're using a guide extension for, if you're going to use orbital, you will require a 7 French guide.
Let me, yeah.
Because an orbital will not go through a 6 French guide extension.
No, orbital will go through that.
No, not with a guide extension.
Okay.
You need a 7 French guide extension
Wait,
so
wait.
that the inner, this thing is 6.
Once we have the viper wire in,
Yeah,
we should be
that's
okay. We won't need the guys.
What do you think? Can we try with the viper wire straight?
I think you should try with the Viper. Viper is as good as workhorse wire. I think it should go, sir.
Yeah. Using Sanjay shape with the viper wire. And
Sanjay will, yeah. Lock. Viper.
One of the things about
7
orbital,
French guide भी एक लाएगा तो JR and a cardio guide plus 2.
the orbital does not cut at the tip. There's a leading 3 or 4 millimeters. That's one of the challenges with orbital, Tejas. Have you had any problems with crossing a lesion with orbital? Rotor will always cross, right, from
Yeah.
the tip. But the orbital does not, the burr is back from the tip. Have you ever had problems crossing? We've had challenges with that.
Yeah, but you could see that with the shape of the wire, I could cross it. Only thing is there is some amount of good grip. Here, I mean, if nothing works, then I may use 1.5 bar and try to double it. Because I'm sure that nothing else is going to work here.
Dr. Patel, a 7 French amplad, sir, might give you a little more support.
Amplad, sir, in this situation, I will be little bit worried to use in view of calcified ostium and a little bit diseased ostium. Sanjay, shape. Okay, he has given the same shape here. Just show. Wire has been given like a sort of a modified Amplard shape. Lateral. Lateral. Inch hai na Sanjay? Say. Wire. Yeah.
Do you have micro catheter there?
No, this is a,
Only the bare wire.
bare wire. Because now, if I can cross with this, I will not need it. સાચવીને ઉતાવળ ના કરીશ. Yeah. Scout. Jodhu.
Yes.
The right direction.
Yes, it is
Scout.
crossed.
Scout, yeah. Thank you, Girish. I mean, I didn't dare to do this because I had not done this with this particular wire.
Sir, I've done it a few times. I mean, the one of the advantages of the Viper wire is that it's a 0.012, which is pretty much the same as your workhorse wire. That's why it also gives you that control. It's very dog friendly also.
Excellent.
Yeah. You said this is a Viper Flex, the one they use? Is a Viper Flex or just a regular Viper?
I think this is the regular
Regular.
wire.
Regular. So we are
I
there.
think a Viper Flex is a little bit better. That's what they said. I use it a few times, and I think it's an improved version, Viper Flex, rather than regular Viper.
લઈ લો ચલો વાયર ક્યાં છે જોઈ લઈએ.
Now the next step is a challenge to how to get the bird down.
Go to LAO now. Go
This
to
is-
LAO.
As Raji said, this is the CSI, the orbital, is not front cutting. So we need the body inside the lesion to cut.
Dr. Kwan, I stand corrected. This is a flex step. This is a flex step. Yeah.
ચલો. Guide catheter, Sanjay. You might have to use Dyna, huh? To enter it.
The Viper wire is also very stiff, and with that band, it's keeping the guide out.
Okay. I am not able to negotiate the wire further because of the grip of the wire, grip of the lesion. Chalo. All this preparation, there is, this milk makes me a little bit apprehensive, but now I am getting used to it. Girish, tell our, or talk, audience, what is the, composition of this milk?
It's a lubricant, so not for vegetarians because it contains egg. But yeah, I mean the infusion rate is only about 20 ml, so you're not giving a lot of, but the lubricant works brilliantly. It keeps the burr going well. The heat generated is neutralized, and because there's continuous infusion and your orbital, the crown is moving, you don't get slow flows. The other thing you'll notice is Dr. Patel does not have a temporary wire. this is the right coronary, and you typically don't require it majority of the time. There are certain times when I have used an upfront aminophylline infusion, which has worked even in situations where there's an increased risk. But overall, for orbital, you don't really require a temporary wire.
Fascinating to see this approach. When we have a subtotal occlusion, we would always prefer rota with a support guide. And it's always nice to see new things. It's an eccentric eruptive nodule, even without imaging. So I think orbital is the go-to device. But when it is a subtotal occlusion, then it's a choice between the two, I feel.
Dr. Patel, do you think a balloon would cross it? What was your feel?
See, only Riuri will cross, but it is not going to make any difference, basically.
No, I mean, one of the reasons is that, I mean, we'll also get a clue of whether this is kind of a calcified nodule or an eruptive. So if you could expand, if it opens, then also, of course, you're taking it past it through on glide assist will also, you'll be very clear from the beginning. In that case, you could cross the lesion on glide assist and then do a retrograde sanding rather than do it antegrade. That would be safer.
Definitely, and that's the big advantage of the CSI over the rotational atherectomy for sure. Plus, you don't have to use a 175 burr to get the lumen that you can get with 125 burr.
Things are not very stable there, yeah.
I think the support is not good, the guide support. So it make the crossing the lesion very challenging in this case. I agree with you, you need to put a small balloon. I think so open up a little bit so we get the donor glide or the glide down and then do a retrograde much better. But let's see a technique.
Yeah, we can go to the Dynaglide. Press it here.
And this is very important. He has selective cannulation. You don't want to do that if you're not selectively cannulated. So we waited for that.
So Dynaglide, okay? This is Dynaglide. Wire, wait. Yeah, there is humming sound here. Stop it. Okay? Wait.
Do you treat this patient anything,
Okay,
medication? Do you treat anything to give aminophylline or anything?
Pardon?
In this patient, the big RCA,
Yeah.
you do an atherectomy. Do you treat the patient? I don't see a pacemaker. We don't do a pacemaker anymore.
We never.
Yeah.
Never.
But do we give aminophylline or nothing?
Nothing.
Okay. Rajit, what do you think? Pacemaker, pharmacological, or nothing?
So we haven't used a pacemaker for rotational or orbital in about 8 years. We go with aminophylline, but for a short segment like this, I would probably do nothing. She's got a tachycardia at baseline, maybe have atropine or aminophylline on standby. How about you, Tak?
I think when I see this big RCA with this calcium, I would do an aminophylline treatment. I agree with you. Pacemaker, I think for us nowadays, almost none, zero. I'm very confident, the rhythm will back. With some coughing, aminophylline, atropine, should not need a pacemaker. Kinto, how about your experience?
Leave it.
You are absolutely right. We don't use or need pacemaker anymore, but we are not using aminophylline routinely.
No.
Sir,
It's simply not, it refuses to move.
So I think it would probably be safer if you took this out, took a guide extension in, San French
I
guide
think so.
extension
I
in, and
think so.
because unless you have your wire very distal,
I agree.
it's also dangerous to.
I agree.
Yeah.
I agree. I agree. So we can remove this, take a 7 French guide, because this refuses to go in. And I don't want to try very aggressively here. We'll wait.
Sometimes glide assist and pushing the wire at the same time
Yeah.
will break this. Because right now your crown is in a very nice position. If you could turn on the glide assist, defeat the brake and push the wire with this situation, this is not a bad option. You can try, because otherwise the option is to change, as Dr. Girish said. You can just
Yeah, it has moved.
Yep.
yeah,
It has
yeah,
moved
that's
now.
it, that's
Okay.
it, that's
That's
it.
good.
That's
So
fine.
we use again Dyna, and this time it worked. Otherwise,
It's
out.
excellent. Excellent.
No. Wait, Anand,
It's really an excellent suggestion. Excellent. Okay. With the tunnel line, push a little bit.
why it's not working? Just wear a glove and do it.
Yeah. I think when there's a blank, that means there's a tunnel line.
Huh?
It's a blank, it's a
We
tunnel
are
line.
pressing it.
No. The buttons are a little difficult, so it requires. Yeah. No, the position of your
Not
thumb
working.
will be a little. They should get this a little better.
Gloves aaphi de fatafat. Huh? Yeah. Just button.
No. Press the
Yeah.
brake down, keep the brake.
Now press it. Yeah, it has worked.
Yeah.
Turn on now.
No, you have to
Turn on.
break it now.
Okay.
Otherwise, it won't update.
Inject. Let us inject and see.
The wire brake is not on.
So we
You
are
have to
at
engage the brake.
Yeah, the
Yeah,
brake
the artery is big. So to start with, what do you think? 80,000 or again the highest, 120?
No, always 80.
Only 80.
Always 80.
80.
Okay.
No, your brake is not
Your
down.
brake, wire brake is not on.
Not, yeah.
Okay.
yeah, that's good.
I am starting now. I am going very slow, millimeter to millimeter.
Yeah.
What is the this thing?
I think that the technique we use for the orbital is very different from the rotor, rotational. I don't know the experience for the panel, but very slow movement, back and forth. So in opposite to rotor, you get a pat down, but the orbital, we let it spin, but you need time for the bird, for the crown to spin. So very slow movement.
Right, but it should never stay at the same place for too
Yes.
long. It has to keep moving forward and back and forward and back. Maybe 2 millimeter forward, 1 back, 2 millimeter forward, 1 back. If you're going antegrade, and the reverse if you're going backwards.
And every run not
That
more
is
than
what
25
exactly
seconds.
I am doing. Little back, little more forward.
So this is the
Little
issue
back.
with the guide support. So if you do not have
Just check
guide
it.
support, the crown remains in the same place, and it's the guide that's moving back and forth. So that's why you need guide support.
And the proximal band is so acute. Once the
Okay.
stiff wire and the the CSI bar is through, it's going to straighten out the segment and push the guide out.
I would really try to cross this on glide assist
Okay.
and then do it retrograde.
Yes, it
This
went
is better.
So-
in. It went in.
Let us check it.
No, you have to get the whole system in again, sir, like what Ajay said earlier.
We are very
Because
near. I
your
think we
wire,
are
the
hitting
soft
it.
tip is very, very close to this thing, so there's a risk of cutting through that.
Wait.
So your wire has to be very, very distant.
Now again I close this like this and then glide. Okay, on glide. Mm-mm.
No, you have to re-platform it.
It's not jumping, right?
So wire is very, very proximal. You have to get the wire
But
down.
we are already here. So
No, you have to re-platform it, sir. You have to
Yeah.
get the, yeah.
Dyna. To what do to do?
Wire.
Wire. Lock. better now. Go in. No. Let me just cannulate it. Inject.
This is the entry point. Is it possible to advance the wire a little bit more with this position?
Not at all, because the guide jumps out.
No, just put it on glide assist, and then you should be able
If
to.
you put it on glide assist, the wire maneuverability becomes
Is
a little
much
bit
easier.
more.
So-
Just use the brake and the glide assist and advance the wire.
Now advance.
આગળ લાયા
There
મશીન
you go.
ડાયના લાયા આગળ હા no, it's not jumping. Why wait, I think it won't work here. No worries, let us, we have two choices. Even in 6 French we can go in with the guide plus and aggressively try to ablate dilate it and then see how it looks. Remove it. Chalo, glide on, out. Okay.
If you're going to go with a balloon strategy, it may be helpful to have a workhorse wire instead of the Viper wire down there.
Yeah.
Delivery is hard. It's a 300 wire, so you could put the fine cross back potentially.
Yeah, that's what we will do. Once we are in with the guide plus, get me guide plus.
So what is a glide plus?
It is a
Guide liner?
guide extension catheter from Nippro, Japan.
I see. Okay.
This is the one. Lock it. આમાંથી bleed થયા કરે છે. Wait, Sanjay. Okay, stop. There is a, bad calcium, even in that wire is refusing to move. So it comes out, wait.
So I think the calcium has really caught the wire badly, and sometimes even the core of the wire gets damaged a little bit.
It's okay.
I would put
Now,
the guide
get
plus
me a
and
microcatheter.
take the microcatheter and put it out of the microcatheter.
So your plan is
Dynamic
just a
is not
balloon
regarded.
the lesion, and then try the orbital again, or try the OCT after the balloon?
I will decide only after doing that. Because I have no clue, so I'll just see. VPCs are, yeah. Oh no, everything comes out, Sanjay. Wait. No, guide plus. Wait, Sanjay. Okay.
What's
Now?
the rhythm of the patient?
There's some PVCs, but a sinus rhythm. Bigeminy now.
Yeah.
Yeah, it looks like bigeminy. Sometimes that's ischemia.
Now the wire is in a good position. See, microcatheter also finds it difficult to move. No.
So one of the reasons why I asked about balloon dilatation is that if you know that it is balloon uncrossable right at the beginning, you would go up front with rota. So that would give us an idea. The second thing is, of course, I mean, not all nodules are rigid. Some are dilatable to a small extent. So if you can dilate that, you would be
A long
also
single marker balloon.
yeah, and you'd be able to get the imaging catheter passed if it say allows a 2 millimeter balloon. But if it's balloon uncrossable, it's straight away rota.
So I think we should be able to get a Rure 1.25 balloon down, and then maybe work beyond that. As I said, we would have switched to a guide long term.
1.25.
So the single marker long balloon has the largest crossing profile is at the marker. So your first, if you have a 20 millimeter balloon, your 10 millimeter are already through the area where balloon marker would not cross through. So you can expand the balloon and get your way through in.
Take me.
But
1.20.
what is the lowest profile balloon we have here?
Yeah, I'm taking 1.25 by 10.
You don't have a
really.
0.8 or 1.0?
We have a 0.75 alveo
0.75?
HP plus or a Nick nano in which the marker is actually proximal. It's not even middle.
0.75.
Those are the two options, but I don't know if they're
So
there
they
in
had
the
only
lab at that time.
1.25 here, so
Yeah.
you may not be able to go.
No, the Rure actually, as he said, the balloon profile is the same until the marker. So the 1.25 will, 0.5 will go even if the marker doesn't cross.
And for the panel, what torqueable microcatheter would you consider? Corsair, Turnpike, anything like that? Mamba?
I mean, this case, I think, not matter about the microcatheter because a very similar profile. I think the Caribou is the one used, but very careful because with this calcification, the Caribou is well known, the tip will fell off. So I try not to using Caribou. I think Franco is an excellent choice, but it's difficult for this lesion, so calcified. I don't know what the panel's opinion.
No, I think that Caravel point is absolutely fantastic. It's absolutely right. You have a heavily calcified lesion. Caravel
See,
tip
it's
is
not
going to...
moving beyond this point. I fail to understand what is happening here.
This is the 125 balloon,
Yeah,
sir?
that's right.
This is the Termo 125, Rure?
Yeah, Ruri.
So then I think we should switch to Rota.
Or even the Viper violation now is very good.
So
Might be able
is
to
this the
get
Viper
CSI.
wire right now inside?
Yeah.
So that is the other thing, that the Viper doesn't have so much of support. So it doesn't have great amount of support for taking a 1.1 millimeter or a 125 balloon because it'll just bend at that place. That's the way in which it's designed because it's nitinol.
Okay. I mean, if we want to do it, we need to change the whole system.
Correct.
We do 7 French with the guideliner inside.
Where is it?
Then maybe you can get a 125 down.
Where is it?
So do we have a Nick Nano on the shelf, sir?
No.
So as a last attempt, we could probably put the wire back in deep into the PD with the guide liner and the balloon there, jam the balloon in the lesion, and then try once more with the orbital. And
Orbital orbital, I don't think with my limited experience in this case now, I may change the, and I will try for another 20 minutes. Let me see.
Right, sir.
Sanjay, what do you think? Rota we have to use now. Huh? 1.25 bar? Yeah, rota, I think so. Microcatheter and rota, but it won't go. That's a problem. But then you have to remove everything.
Not really, sir. We can keep the microcatheter here through this, jam it there, put this wire in as deep as possible.
Microcatheter refuses to go beyond that particular calcium,
Yes,
the
sir,
proximal one.
Yeah, we could.
So, but we have to cross the lesion, you know.
We could jam the catheter in the proximal end of the tapered part and then use the rota wire to cross from there.
Sir, good morning. Can we take body wire and deep parking these two wires?
Professor, one wire, it's difficult. So,
But when we use the gliders, wire is going very deep. So again, guiding catheter is there, so we take two wire and go deep, and because it is Benwood uncrossable lesion. So we deal either by supporting guide or by deep wire throttling.
Yeah, I think
The option is switching to a support guide is always there. I think that is the next step.
Yeah, I think
the tip.
in this case, I think there's a lot of learning in this case. For balloon uncausable lesion, what we should do, A, B, C, D. So I think one is a good guide support. It's a guide extension. I think guide support is very bad here.
Hey, what is at the ostium?
We have to figure out what
Is that
is the
occluded?
step A, B, C, D. So you have good
So
guide
look at
support
this
with
is
a
occluded.
guideliner support.
VPCs
Then
are
we need
because
to
of that.
get the lowest profile. If it's still not working, then the atherectomy. Atherectomy, the orbital is not working, so the rotor very likely will work. And laser
Get me
is the one
run
we
through
don't
now.
have here, but there's a last option.
Run through.
Would you consider changing the guide at this stage, sir?
No. Because almost occluded now, so I may rethink. The most important thing here is I need to see the safety of the patient. So let me work.
But you don't have a wire.
Yeah, I have removed it because it's not working. So again, I am trying with a run through extra floppy and see what happens. Because probably we have done some sort of ablation at the nodule, which has created problem.
Correct. But I agree. I mean, we got to do the best now. But one good option is to really change the guide.
Yeah. And maybe go with the 7 French.
Go to the lateral. No, little more. But that's it. Crossed. Huh?
How's the hemodynamic? How's the patient?
Pressure is 140.
Yeah, the bigeminy was an indicator of ischemia.
Ischemia, that's right.
We could try lateral with the same scout film, sir.
Yeah.
You can see because it's eccentric.
Yeah, go to the lateral, that's the last chance we have.
Yeah, because
We
the
have gone
calcium
in.
is so
Go to lateral, we are in.
super.
At least it's going in some branch, I think. No. Touch wood, we have crossed.
Yeah, looks good. Excellent. Good.
Yeah,
That's very
straight.
good.
I will try with 125 Ruri. Wait, but let me. Again, the wire is a problem.
Yeah,
See
this is
the-
in the RV branch, I think, still, sir. Or is this it? Yeah, that's
No,
good.
no,
That
no,
looks
no,
good.
No,
That looks good.
looks good.
That looks fantastic. Yeah, yeah.
See, the lesson learnt here for the young cardiologist sitting there is how experienced you are, always be prepared to fail.
So do
If
we
you
have laser in the lab?
No, no. Balloon.
So then I would try to trap the guide liner with a balloon outside, sir. Because I think our major problem is guide support. Now we're in a situation where we can't lose the wire, now that we have it. So I would put a guide liner, maybe trap the guide liner in the proximal part of the RCA with another balloon outside it, if possible. And then take in a 1 millimeter balloon to try and make space and then work from there.
See, the villain here is the proximal calcium also, the equal villain. Wire will go now. No. No, this is RV. This is RV.
RV branch, yeah.
Guiding bar, everything is also.
I think, wait a minute, ત્યાં સામે તૈયાર
Now we are here. Now we are, matlab guiding in child. Still we are across lesion.
Yeah. મને કહો, we are in. Wait. સામે કહી દો બસ બસ એમને સ્ક્રબ કરી દો ડૉક્ટર સાહેબ કહી દો I think. See, rather than distal is also very bad, but even the proximal calcium is bothering me.
Is there a proximal wire in which we can anchor this guide for us to help? For now, there are two tiny branches
bonus
there.
branch.
There's a branch proximal.
Let
So
me
we could
check.
put a workhorse wire into that and put a 1 millimeter balloon into that. It might help a little bit.
Sir, guiding is not supporting. Can we replace by jail 3.5 or 3? That gives better support, and we do not face the problem of dissection.
See, I don't know whether you are able to see there or not, but I am not happy with the ostium of right, where I never want to try any guide which I can feel that it can create complications.
Because guiding support is the main culprit.
I understand. But see, the technically, you know what I misinterpreted is I underestimated the proximal calcium. I underestimated the proximal calcium and how nasty it is. Because this tactile feel makes me feel that that is also extremely heavily calcified, area, probably a very bad nodule there too.
Tejas, this is Samir. Do you have a Mac 3.0 or 3.5 guide on
No.
the shelf?
No.
We don't keep it anymore.
Sir, you will easily be able to fix the ostium. I strongly suggest that you switch to an implants. It will make the procedure much simpler. You will easily be able to fix the ostium, trust me.
And once you have the
That is in the event that anything happens to it.
Okay. I will try only for a minute, and otherwise we will rethink our strategy. Get me left implants 1. Only once I will try. We can remove everything. What else? Out.
Sir, if you have the wire goes in, sir, we can exchange with the wire onto an implants also. There's no problem. We don't need to lose access. Oh,
Yeah.
Maybe
ચાલુ
also
કરી દેજો. હું કહું છું 5 મિનિટમાં
maybe
on
also
કર.
consider 7 French as we are doing the
Huh?
whole exercise and get the
જલ્દી
maximum
કરો
support.
યાર. તો કરો સાઇટો સાઇટો સ્ક્રબ કરી દો 11 પેલા પછી બોલાઈશ.
So 7 French amplified, sir, and workhorse wire with a microcatheter loaded up front, and that would be the sound thing. And then once you cross, even if your balloon doesn't cross, you can wedge the microcatheter at the site of the occlusion and go with the rota wire from there.
That's what I would do.
It becomes stable. Huh? 7 French. Side hole check regular. It's okay. 7 French will be slender. We'll try for some time. By that time, if Dr. Saito's case is ready, we'll shift there and we will wait. Hey, super.
Raji, so are you still here, Raji?
Hey, Tak, yeah.
Dr. Malcolm.
So I think the wide course, the wide course is the only the 125 orbitals, not crossing. I know there's a study they do before the orbital trial, the front cutting one. I think it failed or never published or whatever. I mean, do you know anything about the study?
No, Tak, I don't know, but interested to learn more.
Yeah. I think maybe Dr. Saito know about the trial. I heard it's in Japan they doing that, the front cutting the orbital. Few years ago, many years ago, but it never back to market, so I never published. So maybe something you know.
I think this case teaches us that we think the problem is going to be one thing, wiring, and then we get humbled by other challenges that show up in a case. This is very typical for a complex angioplasty.
Yeah, I mean, we see them working hard, but we learn a lot in here, you know.
Definitely. So right now, I think sheath has been changed, and 7 French L1.
I have used the slender 6-7 sheet. Okay. Out.
This is 7 French AL1.
Yeah. Okay. Scout. Scout. Okay. It is always good to keep wise people around when you are doing a complicated case. Go to LO. Yeah.
Now, what is the plan, TJ? Viper wire or balloon?
That's inject and see. At least we are at the previous stage now, right?
Very good.
Yeah, lovely. ECG, Bijamini finished, gone.
So my prediction is now you can get it done in 20 minutes.
Yeah.
Again, I am afraid. Because
I think even the balloon will cross.
rather than the lesion, the proximal bulging is bothering me. It is bothering.
No, I think the guide is sitting very well. I think even the balloon will cross now.
We take rota.
Are you with a microcatheter or just a wire?
This is simply the wire, microcatheter.
So what is our audience suggest? Atherectomy, balloon, or nothing?
Go to lateral.
Who suggests atherectomy? Can you raise a hand? Well, not too many, maybe 10, 15, 20.
I see some of the experienced hand are raising their hand for atherectomy. How many people just think no atherectomy? No. No.
So most asking for atherectomy. So
how many times I crossed this wire in this lesion?
so that means it's easy.
Go to LO. Go to LO.
What kind of wire? Run through?
Run through.
Okay.
But even this, when you push, you will find the guide coming back.
Yeah.
So that tells you that the C of the proximal RCA actually is tram track calcium. So,
Yeah. Okay. Now we can put our guide. Can push it deep in.
The guide pass, this, you're using 6 French guide pass or
Yeah,
5
this
French?
is 5 French.
5 French.
Acha, while I am working on this, will you like, Dr. Saito is ready. Is it okay if we switch over for some time? Then we can get back. It's up to you. Because I don't want him to stay there like this.
10 minutes.
Tell me.
No,
It's up
your,
to you.
your call. We are flexible.
So 5 minutes we will see, and then we will go with Dr. Saito.
No problem.
I'm sure the heparin is being seen by somebody,
Yeah,
the
yeah.
ACT and the
We are
heparin.
always giving a little higher dose, 15,000, in this type of workshops, so that we don't have to worry much about it. And just look at this. This is the problem. I mean, not rather than the lesion. Lesion is also very bad, but rather than that, this is something. Let us go with a balloon assisted.
Yeah, balloon
tracking
assist-
here.
balloon
Can be
assisted.
2 millimeter balloon.
So perhaps we could now push the wire in deeply. This Nipro Guide Plus actually is one of the softest guide
That
extension
is right.
catheters.
Absolutely.
And it doesn't really support, it just tells you where the guide is going to get pushed back.
Yeah, balloon assisted deep intubation will be the best.
Yeah.
अरे यार rewiring to know.
So when you do the balloon assist gacilla extension catheter, what kind of balloon you use?
Yes, wait.
Same
Dr.
as the
Saito,
inner
this is
diameter
recanalized?
of the guide extender.
So you
So
come
about
over there.
20,
You are
25.
needed there. Difficult case.
Maybe 1/7. I mean, this is a 5 French, so
5
I-
French,
two to
2
do now.
so 2 is good enough.
2
Can I
Should
ask
be
the
a little
panel,
bit bigger.
with the 5 French, I've not seen this Guide Plus, but
So
can
I
you get a,
asked Dr. Saito to come because that patient, that was instant 2.5 months total occlusion, 3 months, but on NOAC it has recanalized partially. So now, let us seek, the help of Dr. Saito.
Raji, you have a question?
I was going to say, what can fit through a 5 French Guide Plus? Can you get a 3.5 stent through there or not?
I don't have a guide plus experience, but I think it's the same as a guide liner, gacilla, so you can get 4 stent.
Not through a 5 French.
No. This is. I mean, this is 6 French guide plus.
Got it.
I think the 6 French guide plus.
This is a 2 millimeter balloon, is it?
It went in.
Yeah. So yeah, this is just the guide. This is just the guide. So you can hear the applause in the audience, sir.
We cannot hear you, Dr.
Sir, your
Dr.
mic is
Patel.
off.
Can you turn on your microphone?
Tejas, sir?
Microphone, please. Hello, am I audible?
No, only through Dr. Sanjay's mic, I think. Your mic is not working.
Hello.
My mic is not working.
So, yeah.
Yes, nice. Very nice. I have reflected. Reflected. Yes, बस काटना क्या balloon काटना है.
Will the balloon go further?
Yeah, I'm sure it'll go. I think we need to get
We have
the,
already dilated. अच्छा थोड़ा बता.
fantastic. So we need to get the Guide Plus out and then maybe an imaging catheter in. Now that the 2 millimeter balloon is gone, I think the imaging catheter will easily cross.
Someone takes it.
I am struggling since last 1 hour. It is your case.
So, can you just play?
Is it? Let us check it how it works because
Are we planning to deliver the stent straight away?
No. Because it remains unexpanded, we are in trouble.
No, I mean the guide plus is beyond the lesion. So
I know. Purposefully it has been done. Run through extra floppy.
Can
Give
you
him mic, Dr. Saito.
can just take a quick check to see what's happened to the lesion?
It is at the lesion.
We can take non-compliant balloon.
We can try with a non-compliant balloon here, and then you can.
So I would actually put in the imaging catheter and then see which atherectomy device is the best.
We have done it with 2 millimeter RURI, dilated. So it is a dilate. Yeah.
So I think now we have to change the wire.
Yes, but okay. Do you want me want to dilate further? No. Enough.
Dr.
So
Patel, I
we
think
can change over.
imaging catheter will go in. So why don't we get data on what we are dealing with and then decide what to do next?
OCT. Get me OCT.
But
We need to remove this. Now OCT, we can work with OCT with a guide plus, right? Should not be a problem.
Not a problem, sir. You can even do a saline OCT if you want through the guide plus. I mean, the thing is, when you're giving contrast through the guide plus, sometimes you don't get perfect clearance. You have to pull it back a little bit and then give a really powerful injection. But it can be done through the guide plus very easily.
One of the things you could do is keep the guide plus there till the imaging catheter crosses, and then you can pull the guide plus back further into the into the proximal part of the RCA, and then inject through the guide, and you'll still get very good. And because the other thing is that we need the images all the way back to the ostium almost.
True.
So you need the guide plus back.
Agala, bring it further. I am in, and I am. It is in, right? Okay.
No, not yet. You have to go past. You have to go in a little more.
Check it.
No, you have to go.
Bit more.
Yeah, little more.
Go a little bit.
Try to take the curve there.
So if we pull the guide plus catheter back,
it will go.
The imaging catheter will go in.
Okay. Now we don't have to do anything. It has come out purposefully. Yeah. Just check it. Huh?
we take image.
If we pull the guide catheter back further,
Guide
we can
plus.
have a guide plus further back. Then we can have idea about the proximal lesion also.
Yes.
What do
Absolutely.
you think?
Yes.
Yes, it's a great idea.
Why to lose that access?
Huh?
No, we can always put it back.
No, you can put it back.
Okay. Chalo. Just check it first.
You will get.
Position. Check the position first, Sanjay. Looks good. Wait.
So you could keep the tip of the guide catheter, guide extension just.
ખજૂરી વાળા લગાવવાનું છે પણ ગીતાને બોલાવો આને પાઠાવો એને બોલાવો ગીતાને કે ખજૂરી વાળાને લગાવી દો અહીંયા તરત અને બધું તૈયાર કરો અને મીન વાઇલ સંદેશ મહેતાને અહીંયા કહીએ એટલે લઈ આવજો યા પ્રોફેસર માલ્કમ બેલ વાય ડોન્ટ યુ કમ હિયર we have the image. Yeah. So, mic is not working. Yeah.
Not well. Poor image.
Poor image.
I'm not sure the reason why.
જો તો મેં કર્યું ફ્લોરો
આનાથી જ કરવી પડશે ચલ ના
બરાબર છે ગાઈડ પ્લસ છે ને અંદર થોડું અંદર નાખું ઇઝી ટુ ઓર વી ડોન્ટ ડુ એનીથિંગ Okay? Huh? Professor, are you able to interpret the image now?
Yes. So, here is the tight region, right? Yes. Okay. Right. By ballooning, you can identify some. This is a little bit distal, right? Here.
Yeah.
some calcium here, right? But I just moved to the proximal. Here is a nodule, right? Nodule comes here.
Nodule.
Yeah, big nodule here.
Bad nodule.
And by ballooning some, yes, dissection here, but almost all calcium, right? And then I can identify some dissection here. And this is the blood, so tight, yes, tight lesion. I'm not sure which direction, so Saito Sensei, I think this is the better to do the orbital pullback manner, right? Yeah, yeah.
Pardon? Yeah. Orbital pullback.
Yes, yes. Because here is the nodule and the wire is here, so and the opposite side is no disease or mild disease here. Therefore,
So we do, but orbital again. This is a 5 French guide plus. Orbital won't go. 7 French is the guide catheter. Guide plus is 5 French.
So right now you balloon that
Guide
already.
plus
I think you can take out the guide plus. You have the M plus
Okay,
guide.
then come over. Please take over. But okay, are you able to hear Dr. Shigeru Saito? Hello?
No, we can't.
No.
Yes, yes, we can. We just heard him. That was him speaking.
Say something.
No, we
No,
cannot hear.
no, we don't hear him. We don't hear him.
Dr. Akasaka, in the meantime, can you show us the proximal calcium? There was another nodule in the proximal artery.
I try, yeah, but the image is not so good. But here also
That's a nodule.
We have a nodule, right? Yeah.
सुनाई नहीं दे रहा है उधर. My mic, you
Here,
give him my mic, gentlemen.
you can identify some
It's okay.
nodules, right? And
Yeah. Just a moment.
yeah,
Changing
but
your mic.
we cannot see much more proximal side. But here we can identify the nodule, another nodule. So might be some slumps there. Therefore,
Can you hear me?
Yeah, damaged
Yes.
by the yes, extension catheter, right? Small, yes, please.
So in my view, the next steps would be 1, remove the guide plus, 2, take a wiper wire parallel to the existing wire.
Just listen, Dr. Saito has a strategy and he is taking over from me. He and Dr. Akasaka feels that we do orbital atherectomy reverse ablation, right? From distal to proximal.
Yes, yes.
And Dr. Saito says that 5 French, 1.33 millimeter diameter orbital atherectomy is, guide plus is okay for pushing.
1 to 5.
No, it's not okay.
It
It's
is
not
not
okay.
okay.
It is not okay.
Not?
This,
No, guide plus 2, the IR ID is 5 French, so orbital will not go through that.
this is 5.
So
6. This is 6 French. Okay, good. Fortunately. So
No, internal diameter is 5 French.
1.33 millimeter.
That's not recommended, sir.
This
It
is
won't.
6 French. Okay. So just remove this OCT catheter.
これでいいんじゃない？いや、なんか今。This is 6 French? 6 French.
Out. So Dr. Saito is taking over now.
Okay.
And that's it. So this is the issue. You can inject and see, Sanjay. Remove my mic. Dr. Malcolm Bell ne aapon pelu mic akar de.
Can you show us the fluoro screen? You're on the OCT right now.
Okay. Yeah.
So if I may suggest something, one, the guide plus which is there has to come out. Wiper wire, parallel wiring with the soft wire, pull the soft wire out,
OCT,
take the orbital down and retrograde sanding. That should do the trick.
だからマイクロ。So first, I have to change the wire to wiper wire. Kita? Kita?クロスしたね。ちょっと待って、なるべく奥まで行く。で、バイパーワイヤー、プリーズ。チップ見える？どこにあるティップ？うん、いたいた。うん。Orbital.
Orbital, please. Not yet.
これと
まだですね。来ました。
入れていくよ。
はい。
あ、ワイヤー、ワイヤー、ワイヤー。うん？抜けちゃった？よし、これでいい。ちょっとこっち来て、こっち来て。そこに落ち着けちゃうとダメ。ああ、抜けてる、抜けてる。よし、はい。ちょっとそこ浮かさないと。
はい。
それ、ワイヤーが固定されてるでしょ。
はい。
違う？
いや、してないです。
してない？
はい。
いくよ。もうちょっとこっち来て。
はい。
もうちょい。
はい。
こっち来て。
はい。
あ、ワイヤー抜けてるよ。
ちょっと。
ワイヤーは引っ張んなくていいと思うんだけど。
はい。
Perhaps we should check the proximal edge of the guide plus. I think if the crown has not entered it, you can check on the fluoro.
Okay. You can see now.
But looks like he's moving well.
Moving.
That's fantastic.
I mean, that's excellent demonstration. The catheter, the guy sitting there and not moving, and the extend catheter is not moving. Looks like going down.
Looks very nice.
It doesn't look like you have the glide assist on.
Yeah. Glide assist. You're coming. So first I cross this region. Okay, already crossed. Okay, stop. So, ちょっとどうや。Okay, okay. This is locked. Okay.いや、いえ、分かってる。じゃあ、ちょっとこれ抜こうか、全体を。ちょっとこれ、ダイナ。
No, now that your crown is passed, it might be a good idea to get the glide assist, the guide extension back so that you don't ablate that.
Yeah, I think that's a good point. You could actually see that guide extension being pulled towards the lesion as that orbital atherectomy device was being pulled back.
Yeah.
No. ワイヤー入れてってね、これちょっと抜くから。じゃあ、いや、もう。
Should we do more ablation?
I mean, there are two nodules, so one of them is in the area where you have the guide extension right now.
Yeah,
so the guide extension has to come right
back. Right
up to the ostium.
Right up to the guide.
Yeah, 撮影。It's too far. And Dynaglide. Wire in. はい、OK。はい。いいですか。じゃあ、ダイナでしょうか。ダイナ。ちょっと待ってください。今ダイナです。いきます。こっち来て。はい。Okay. はい。
You see how easily that goes across now.
じゃあ行くよ。Okay. はい。ちょっと待って、これ入ってない。
入ってる
Wire break.
はい
Wire break.
入ってる
はいちょっと
いやいやいや
ちょっと混乱してすみません先生
Okay, stop. So shall we remove using Dynaglide? Okay. Okay. Okay.
I think you should ablate there also. There's a nodule there.
This is Dyna.
You have to press it, na? Press kar de.
Yeah.
Do it now.
Yeah. Wire in.
Yeah,
Dyna.
Okay.
Dyna is on.
Yeah, now it was on before. Yeah, on.
Tak and Ginter, just whilst they're sorting this out, there's a lot of communication challenges here. Anyone in the panel have any thoughts about, on another day, whether a rotablator would be a reasonable option at this point, other than, instead of orbital atherectomy?
Slowly. Oh, slowly.
The advantage and disadvantages are like, the Viper wire is much stiffer wire. So that proximal C band that was kind of causing the railroad calcium and was pushing everything out, Viper wire will enhance that problem versus the Rota wire would not. The advantage of the CSI is that it would, at a 125 bar, give us a bigger luminal gain or the effective atherectomy area. Versus the rotational atherectomy, you will require a 175 bar and at least a 7 French guide, which we have here. So that's not a point. And the last advantage to me is like having been in a situation where the rota burr gets stuck beyond the lesion, if it jumps through and then it does not come back out. Versus here, CSI, you can do ablate both sides. So even if the burr jumps beyond the lesion, you can atherectomy your way back out of it. So you never have to become a surgical emergency.
Yeah, I think those are really good points, and I think that's the one thing which you when you're doing this with rotablator, with trepidation and making sure that you do not get the burr stuck. And again, I think the point about the 7 French guide, if you're going to be treating something like this, actually even without rotablator, I think this vessel is big enough for 7 French guide, and it just gives you so many more options, doesn't it? But certainly rotablator, you'd have to step up your burr size.
Regular wire.
But I think we've already seen here now. I missed the action before the no reflow. I was traveling down here, but just watching this now, you could see how just easily that went across and then pulled back. It's a really nice demonstration.
No, from the beginning, I can see something. Micro.
Tejas, you were concerned about the ostium. I just wonder whether that was some eccentric alignment of the guide there. I noticed the same thing, but I think very appropriately you emphasized at the very beginning of this case, to be cautious with using Amplat's guides here. On the other hand, I think this is one of those cases where it's easy in retrospect, but certainly the Amplats has really helped here. And I haven't seen any sign of any pressure damping or any contrast staining, but you just have to remain vigilant watching this and making sure that you're not just watching your wire, you've got to make sure that you're watching that guide position.
Among the multiple learning lessons from this case, somebody had tried for 2 hours with some very aggressive wire and unable to cross the lesion. While we saw it today, Dr. Patel crossed it like a few times, not just once. But I've seen over the years, he can put a JR4 guide into mid-RCA and make a very supportive position. But the proximal calcification in the proximal calcified nodule did not allow it. And using the supportive guide kind of changed the situation. And as you said, Malcolm, the pros and cons of using an aggressive guide which can cause aortic dissection and create a surgical emergency versus a non-supportive guide that doesn't allow you to finish the procedure.
Yeah, I think that's a nice summary, and I think it all depends on what your experience, what you feel comfortable doing. I think I personally would have gone in with an Amplex guide at the beginning. You never really know what all the issues were with a case that was done elsewhere, but with the idea that you're likely going to need a guide extension. The other thing too, with all that proximal calcium and everything, it's just that friction on the wire is just making it difficult as well. But let's just go back to the first thing you said. That was Dr. Patel, yes, he crossed this, but I think it was within maybe less than 10 seconds of the first attempt. But we should all remember that. Also, when I was sitting in the auditorium and I was talking about Sanjay's approach to this in terms of choosing a sort of an unusual angle, I think actually we used those left lateral, right lateral projections. I think we used them less common than we should. But I think it's just so good, particularly for the right coronary artery, and then sometimes even for the LAD. It's a little bit harder now with doing radials as well, to get that full 90 degrees. But I think that was a wonderful demonstration that you could see it, and it's very, very good for that mid-right coronary artery, particularly if it's tortuous, or if you've got a big RV branch that you're really trying to see or protect.
OCT.
So this is all looking so much easier than it was an hour and a half ago. Would we agree? Or I don't think it could have got much more difficult.
先生、OCT の、ここ見ますから、なんか通らないんですよ、意外と。通らないんですよ、今。
Kinter and Tuck and others,
extension catheter.
I don't want to harp on about rotablator too much, but we saw on the OCT and maybe Dr. Akasaka still, yes, he's still here. So when we see, those dissections there, did anyone feel afraid of atherectomy, whether it's orbital atherectomy or rotational atherectomy? That question always comes up. Maybe Dr. Akasaka, what we saw in the dissection there on that earlier OCT, anything there that would make you concerned about atherectomy, whether it's orbital or rotational?
I think, yes, I would like to say, yes, push-in manner by Orbital makes some dissection in the normal site. Therefore, it's depend on the wire bias, but the pullback manner might be much more safer to abrade. And yes, and rotational atherectomy is sometimes makes
difficult,
much more wire bias.
Maybe we need a balloon. Yes. No, semi-compliant. 2.5. Not to respond.
Do we still have Viper wire in, or is it now the workhorse wire?
I think the Viper wire is still there, correct?
Yeah, that may work against us also because of the stiffness of that wire.
Yeah, just confirm that that wire is still in place. I think another just observation here, I mean, there's obviously a lot of people investing a lot of energy here at the moment in terms of getting a good result. I do think that in many labs that they may have just sort of panicked at this point and just ballooned it and put a stent there when they had that support. But I think what we're really trying to do here is optimize that result, because it's going to be difficult. And I think kudos to the team in making sure that you're continuing to use intravascular imaging, but again, I'm just interested in what the panel might say. But it's been my observation that very often people will just decide they're just going to balloon this and stent it and just accept the result.
I think, well said. They are not only want to do a stent, they really want to optimize the stent result. I mean, we know we need to get a good acute result, and also we need to get a long-term result. And imaging in this case is very important. I think they try to do another OCT just to see the nodule get ablated or some crack on the nodule or not. But
and the other part about
if the balloon is not going, the microcatheter is not going down, I think I believe they need to do a little bit more work in this situation.
Cannot cross.
Maybe ablate more, maybe they need to do an IVL now.
Yeah, and I just brought that up because you remember Anand made that point yesterday. You're going to do this properly. After each step, you go back in with your intravascular imaging, whether it's OCT or IVUS. You just have to be prepared to do that.
Definitely.
And I think we're seeing a great demonstration of that today. So did everyone see that with the guide extension? Just actually went across the lesion without any balloon in front of it? I haven't used this one before, I don't think, but... Well, that was very nice. Yeah, I was hearing that you have a lot of good experience with this particular guide extension. I think everyone might have missed that, but Tejas making very reassuring eye contact with the patient here, who seems to be very comfortable.
More proximal. Here. Just a moment. This is too far. Okay. No, more.
So this is a 2.5, 15 Uri from Chirumo. This is semi-compliant balloon.
Should be now.
Tejas said, Dr. Galati and I often reflect on these guide extensions, and that these really have been a game changer. If you think about the few developments in interventional cardiology, we get sort of new balloons and new stents, but there's not a lot of difference between the stents today. But this case would have been just about impossible 15 years ago, or whenever, the pre-guide. Although sometimes, we would, you may remember this, sometimes we would get those guide catheters halfway down the right coronary artery, but then you had to be very, very brave.
Hello, Kintur. Hello?
Yes.
Yeah, is it audible?
Yes, you are audible.
Yeah. I mean, we have another case ready, but we will wait for 5 minutes here, or within 5-10 minutes should be over. And if you guys are tired, we can change the panel, or else, it was 9 to 11. Okay, we are a little bit delayed because of this case, but fine.
There is a lot of learning through this case, and yes, absolutely, we are ready to change the panel.
Tejas, no one said this case was going to be easy, did they? I don't remember hearing anyone say that.
I never thought that it is going to be very easy, because somebody has tried it for 1.5 hours. But that was a young guy, but who could not even cross the lesion. But I was afraid, looking at the character of the calcium, I never thought that it is going to be a simple cakewalk.
That's a good point. I was really maybe alluding to that earlier. When we see these cases that there's been some failure at another institution, whether it's a failure in getting good pictures or catheter engagement, very often we think, we have the solution for this, we can do it, but very often it turns out that there actually is some issue that is going to make it more difficult. So I think we always have to be very respectful and humble in terms of our approach to these patients.
For the final session, we'll have Dr. Samir Pancholi, Dr. Ajay Mahajan, Dr. Lachuman Das, Dr. Pintu Nahata, Dr. Tarun Madani, Dr. Dinesh Joshi, and Dr. Hariom Tyagi.
I know we got a new panel coming up here, but
yes. I think the Lesion is something.
There's a lot of people cheering from the back here. One other thing about the guide catheter and that the concern about the amplas. When you have these guide extensions, it does allow you to have the guide out a little bit and maybe protect that ostium when you're just covering it with the guide extension.
It's a good point. Looks like the fine cross is having a difficult time crossing the dilated lesion, right?
Yeah.
I think very strange. The extension catheter can pass, but this one micro cannot.
Because I think it is hitting wire bias and it is hitting the nodule part.
Dr. Saito, do you think putting a tour balloon at the tip of the microcatheter, of the guide extension catheter, and trying to dive deeper past the lesion?
We have already gone inside across the lesion with microcatheter, Samir, several times. I personally feel that we can use a regular wire, by the side of this wire, this will give extra support and we can stent it now.
Yep, yeah, free wiring next to it is good.
Yeah. It's up to you, Dr. Saito.
But I don't think that we can cross by using the balloon.
That will happen when once we have two wires, because it has already happened several times in that region, right?
So how do you think?
I think
quite strange.
We can go in with an extra, extra floppy wire across it. So there will be two wires.
Okay.
Then on extra floppy wire itself, you should be able to deploy, the short stand there.
Really?
What? Yes.
Okay.
You can do that.
So, shall we try regular wire, 14,000 wire, parallel to this system?
Microcatheter should be removed, Sanjay? Or else, yeah.
Just another advantage of having a 7 French guide there, just gives you so many other options run another wire down alongside this. You would not be able to do this in a 6 French.
Okay.
This is the good shapes.
Oh.
This is the Sanjay's AL we have created. It
Ah.
will go to left lateral.
Okay.
That will give a precise idea about the direction.
I don't know if everyone heard that, but Sanjay is again using his custom tip shape of the wire to get across.
He's had a very good track record so far.
Yeah. Although actually I should say, actually it's not, I don't think it's Sanjay actually doing it, he's actually handed it off to Dr. Saito to do.
Mm-hmm.
Yeah, I think if you pull the guide extension back, right? Is that what you're saying?
That's exactly what they're recommending here.
Yep. It might be under something. That is true. It's in the RV branch, bro.
I know we've got a patent lawyer in the audience still. We're probably we should patent this wire tip shape. Could someone write it down on a napkin?
This is the RB. Yeah, please.
I think that looks different. Yep.
Catheter, I think you should easily be able to push your stenting. Not easily, but yeah, you should be able to do that.
that was a good correction, I think.
So I have to use this one, no?
Pardon? You want to dilate
this one?
What? Yeah, this is run through. Guide extension is on that wiper wire, right? So, any
Tejas, any role of IV, any role of IVL here? No.
IVL balloon will not go inside for sure. What do you think, Dr. Sai?
I think right now this is 14,000 wire.
Yes, yes.
So we try to cross the balloon.
Balloon. Get the balloon. Which balloon? 2.5? Huh? Get the new 2.5 balloon. Huh?
この枯渇？
ガイドエクステンションそうそうもうバルーンで。
そうか。Yeah, we just talked about this this right lateral position here, but I do think we have to be careful of the radiation exposure. So this is a yeah, no, I understand that, but I'm just pointing out that when we do use these, just use these for a minimum amount of time, because all that scatter is coming back here.
I have to remember.
No. That's why sometimes you can just invert and do a left lateral. You're going to get less radiation.
Needle. Okay.
So the guide extension has been now removed.
You're going with the old flagged 2.5 balloon?
Balloon, yeah.
New balloon.
It's a new balloon.
Because I really don't want Dr. Saito to suffer with the used balloon. He has already suffered.
Yes.
Dr. Saito, this suffering is lesser than that RCA CTO suffering, right? Yeah.
Coming. Coming. Close? No?
No.
No?
Yes. Yes. Inject and see. Inject and see. We are across.
I think the buddy wire really worked.
Adjustment.
Yeah.
Okay.
Yes. You can dial it here also.
Yeah.
Samir, in terms of the buddy wire, how often you use a buddy wire these days?
I think a lot of times, even preemptively. Tejas actually taught me that. You put it before you start even ballooning.
Okay. Yes. 3.5.
You will like to use Giant Sierra or Onyx Frontier.
Up to you.
Giant Sierra, you think it will track there?
I don't know.
I think we're going to find out.
It should now. Now it should be easy for them. Saito, can we inject and see?
Yeah.
It's a recoiling type of calcific lesion. Much better.
Okay.
So, 3 millimeter?
Yeah.
Yeah.
Okay. 3.5.
3.5?
3.5. Yeah.
3.5 by 15. 15. Here. Dr. Saito, what do you think now?
Dr. Akasaka, side stand, do you agree with this?
Yes. We are now the measuring, so maybe 3.5 should be okay. Yeah. 3.5. Okay. Try to check the lens.
You just want to use a short stent for the tight lesion first, right?
Yeah, try to put show the
Well, I think only that part, Samir, needs to be dealt with, I think, at this point of time.
Yep. And then you deal with the proximal nodule and all that afterwards.
We may not even touch because it, on OCT it doesn't seem to be, obstructive lesion.
That's right.
It is not an obstructive.
Okay. So you leave it be for now. It's good. It's good. That's a good strategy.
But maybe we just keep an open mind because we've been doing a lot of pushing down there as well. Short stent here, OCT run, make final decision about that proximal segment. Yeah. Do you believe in contrast-induced nephropathy? There are a lot of controversy, and we have nephrologists who do not think that exists, particularly from a radial approach.
This thing, I think we had discussion with Rajiv, and Rajiv feels that the terminology does not exist actually because it is the embolic type of problem with the kidney rather than contrast. I think.
But what I'm saying is that, I mean, if there is some lesion there that may need treatment, maybe this is the time to do it. You don't want to bring this patient back again, do you?
No, difficult. No. So it's difficult. So I want to take the extension catheter.
Do we have the wiggle wire, Tejas? Is it available?
Wiggle wire will create more of a wire bias and it will create problems, what I feel, because it will make the area very straight in that region and I don't know. Instead, guide extension is a better idea.
Yeah, definitely, but if it still doesn't work, I think the wiggle might be one option.
Samir, I mean, that's a great suggestion, but I think there are only so many learning points we have in this case.
And 14,000 Yeah, okay.
But this is the same extension you used before. Yeah, so there should be plenty of room here.
But here I have resistance.
Yeah, I think it's that mid nodule that's blocking everything.
Yeah, that's the one we we're just talking about again. It's a sort of a nuisance nodule. There we go. Should be pretty easy to advance the stent there now.
It's still not easy because now the guide catheter will come out and not give the support.
You consider moving that guide extension even more distal?
Guide extension?
Yes.
This will be a good case for vasocatheter advancing the guide extension all the way down to the distal right.
Something about the vasocatheter.
So it's the balloon assisted tracking type of a mechanism with another anchoring balloon inside the guide extension, and you lead it with a leading balloon and it eliminates all transitions and gives you pushability.
Yeah.
Here also in fact, once we do get this stent across before we deploy, we're going to almost certainly remove the other wire. We certainly want to jail this up against all this very calcific disease.
Here also, if we put a 2.5 millimeter balloon distal to the and then push the, after inflating the balloon, push the guide extension catheter.
Yes. There we go.
Yeah, it'll be through. Yep, it'll be through. A little more, right? A little more. Little more. Half a stent length more. That's awesome maneuvering of the amplats using the sinus of Valsalva. Amazing.
So,
Dr. Saito removed the body now.
Yeah. で、これかぶってるのまだ。
少しかぶってます。
どこへこれやな。これやな。これ抜くで。はい。これ いい？
そうですね。ちょっと撮影して撮影します。
うん。OK？行くよ。もう。
もうちょい先に行かないといけないですね。
行かない。
Guide extension, we slided over the catheter.
You mean just like that?
How do you think? Just a moment.
It's still a little short, I think.
Yeah.
I think it is still good. It covers.
Yeah, cover.
It covers.
ちょっとこいつもちょっと抜かないと。
はい。できます。ガイドエクセンスできます。あ、今ちょっと。
はいはいはいはい。OK。
撮影します。そのまま行きます。
そのまま行こう。
はい。行きます。
So here we go. Fingers crossed.
Yes.
12ですね。今3で。
14。
はい。
What is the gut feeling? You know, from the panel. I think it is almost it is covered.
Almost is covered. Yeah, almost is true. I think there's a little bit left distally, but you can get a short stent through it now.
No, we will not do that. For sure.
It almost covered, sir.
It's just about covered, but there is some uncovered lesion.
But it's nice the way the stent was fully deployed.
Personally, I strongly believe that calcified lesion, small dissection here and there, they don't recoil because there is hardly any elastic tissue to recoil. So, and with availability of Brilenta and the new antiplatelets, any problem of stent thrombosis we really don't expect.
OCT.
True. No, I think they are less floppy. It's true.
Perfect. It is just, it is covering the edge of the lesion. OCT?
高橋先生聞こえますか？
これ、どうだでやってるの簡単に。
ですね。すごい投げっぱなしです。
OK。OK。どうして、まあ、インジェクション。そう、はい。
Right.
Difficult.
I really troubled you this time.
Yeah.
I have a right to trouble you.
Yes. Yeah. Still a little bit contrast here, right? But okay, try to move the proximal, right? Here. Yes, a small calcium at 12 o'clock. Yes. Here might be the edge, right? And then, right. Okay, the upper side might be the severe calcium, right? Then position might be okay. Right, and this is the proximal site. And here is the branch. Yeah, right. Understand this a little bit upper side of the branch. This is yes. Here is yeah, proximal side of the stent, no strata here, right? So I think the expansion should be acceptable. Yes.
Okay. So
should we conclude on this case? Maybe taking a couple of views, Dr. Saito.
Okay.
So this case, we will be concluding, and please be ready for the next case, which I am sure will not take more than 30-35 minutes, but it is going to be very interesting case of anomalous circumflex artery arising from RCC and a very long lesion. We will see how to work.
Which direction you want? Which direction?
I mean,
no.
The view.
Yeah.
View. I think we can take one epicranial view,
okay,
or aleocranial. Aleocranial will be perfect for this lesion. Yes. Yeah. It looks fine, huh? Thank you, Dr. Saito. It was a great case, and I want to, Samir.
Yep.
I mean, there must be good number of people, doctors sitting in the audience.
Absolutely.
I want to give you guys a pleasant surprise, and it is the wish of the patient. You guys remember? Hello, can you hear me?
Yeah, absolutely. Yes, go ahead.
You guys remember the first case which developed full-fledged pulmonary edema, and we had to quickly stent his left main and LAD, and it was the saturation dropped to 64, the blood pressure was in 60s, 70s, and all of us were quite tense. And see, in the morning when I was taking the rounds of the patient, he told that I know that many doctors were in the audience were tense. I could listen your conversation with them. I will like to reassure them that I am fine. So just wait for some time, and he wants to speak something to all of you.
Oh, that'll be
This
great.
is his wish. That's why I have called him. He is the patient, and you can see.
Wow.
હેલો, માય નેમ ઇઝ શૈલેષ બેટા. હું ગઈકાલે મને ટ્રાઇકો 2025માં પ્રથમ સ્થાન આપવામાં આવ્યું તેજસ સર મારફતે. એમના માટે હું એમને અને એમની ટીમનો ખૂબ ખૂબ આભાર માનું છું. ગઈકાલે મને જે પ્રમાણે કોમ્પ્લિકેશન હતી એ પ્રમાણે તો મારે બાયપાસ જ કમ્પલસરી હતું. મહેસાણા હું રહું છું, મહેસાણાને એનટી પટેલ ડૉક્ટર અને રમેશ રાવલની હતું કે જો તેજસ સર કરે તો જ આ શક્ય બનશે, બાકી તમારે બાયપાસ જ એક વિકલ્પ છે. પણ સાહેબના ખૂબ હોશિયારી, સાહેબની ટીમ દ્વારા જે મને રિઝલ્ટ મળ્યું છે આજની તારીખે હું એકદમ ઓકે છું. એક દિવસમાં મને કોઈ પણ તકલીફ નથી. આજની તારીખે હું પોતે હતું એના કરતાં વધારે ફિટ હું પોતે અનુભવી રહ્યો છું. અને ખૂબ ફરીવાર આપ સૌએ મારા માટે જે ચિંતા વ્યક્ત કરી અને મારા માટે જે મને સાંભળવાનો ચાન્સ આપ્યો, આપ સૌનો ખૂબ કોટી કોટી વંદન.
Thank you, Shaileshji. Thank you. So, this makes me feel good that, it was such a tense moment, yesterday. And you guys, within 1 minute, we are shifting to the other lab, so be there, and this is going to be a very, very, sort of an educational case over there. Thank you. I'm just going there.
Thank you, Tejas. That was amazing. Thank you.